to you all. A very warm welcome to this Western Cape Provincial Parliament Ad Hoc Committee on COVID-19. Today is Wednesday, the 1st of December, and we will be meeting with the Health Department today. I'd like to extend a very warm welcome to the members here present, as well as a very warm welcome to the Western Cape Department of Health, the Minister, Dr. Nama French-Mbombo, the Head of Department, Dr. Kluti, as well as the officials from the department that are joining us today, as well as any members of the public that are joining us on social media, as well as members of the media corps that are in attendance today. I have not received any apologies for today's meeting. Are there any apologies that need to be tabled now?
Chairperson, good afternoon. It's not an apology, but I would just like to request that I leave at 3, if that's possible. Okay. It's Gideon Bosman.
Thank you, Honourable Bosman. And we'll take note of that. Any further apologies? If there are none. Yes, Honourable Van
Yes.
Good afternoon.
Member Piet Lekker.
Thank you. We will make note of that apology. Thank you. All right, before we get into it, let me quickly remind everybody about the rules of engagement for virtual meetings. All members are muted at the start and during the meeting itself, and that is in order to avoid background noises. If members would like to flag any points of order, they may do so using the chat function or by using the raise hand function. We ask that video and audio be turned off to help us improve the quality of the connection. However, if a person is making an input, of course, please do use your microphone, and we would encourage you to use your video and then to turn them off once you have concluded your remarks or presentations. And then, of course, as always, the maintenance of order is in accordance with the directives for sittings of the House and meetings of committees by electronic means, which was ATC'd on Friday, the 17th of April, 2020. So today is scheduled as our last briefing by the Department of Health for this year. We've asked the department to brief us on the progression of the COVID-19 pandemic in the province, with specific reference to the major indicators, modelling, situational analysis, which of course will include the identification of the new variant, as well as prospects for the 4th wave, and then importantly an update on the vaccine rollout, including vaccinations for the 12 to 17 age cohort, as well as information on any boosters for healthcare workers or the elderly. So with that, I'd like to extend a very warm welcome again to the Minister, to Dr. Kluti, and then I believe that Dr. Balabji and Dr. Mudli are also on the line. Very good afternoon to you all. Let me start with you, Minister. Would you like to make any introductory remarks?
Thank you, Chair. I just want to apologize that I'm on the road. So in between, I'll be switching off my camera so that we can have more network. Thank you for the opportunity. Good afternoon also to honorable members and everyone is here, and also to the department and also to the media. I think, Chair, because it's our last meeting, probably I also want to highlight, before we even go to the COVID, to highlight that today is a World AIDS Day. And it is crucial for us to acknowledge that part of it, because it does have an impact on the COVID that you are speaking about, especially also it is about also providing the ARV additional doses to the people who have got a CD count of less than 200 for those who are HIV positive, because it's part of the immunosuppressed people, which include the cancer patients and all of those, but it will require a referral, whether it's a professional nurse or a doctor in regard. So it is indeed a breakthrough. Now about the others, because you might ask about what about the others. Now the others at this stage is the Pfizer, who have applied for the through SAPRA in order to have a booster for the Pfizer. Currently, the people who are on the booster is the healthcare workers who are part of Sisonke, The Sisonke is the one that started in mid-Feb. So these are the ones who have already vaccinated more than a third of our staff using the J&J. But in our circular and also going forward, we are looking forward to that when now the policy allows it, and also based on our advice from the clinicians and also from the scientists, will be ready actually to vaccinate to provide the booster for the others. Currently, it says that at least it should be about 5 months, the average, 5 to 6 months, the average in terms of getting the booster for the ordinary people. But we'll just wait. So it means that if we have started with the older person in May for the Pfizer, and then their second dose will be around July. So it means that for the others, older persons specifically, the ones that we started with, it could be around January, February, March. So that is the first part. Also, Chair, I want to acknowledge that we are in the 16 days of activism, which is part of the whole of this, specifically around the gender-based violence. Again, it does also have a huge impact also around the COVID. Because the data from elsewhere, it does show that there are more women have been abused during the lockdown. Actually, they were locked down with the abusers, especially at the time of the lockdown level 5. And also that we have already now yesterday being provided about the state of unemployment in the country. We do know that with the COVID and with the lockdowns and also with the economy, it mostly those jobs in the hospitality sector, which is, as we know, that it's mostly women who are working in those. So it's a women actually who lost more jobs in this industry. So that's why it's crucial we speak about that in terms of the gender-based violence. Now, coming to what we requested, again, the definition, which is the HOD and the team will also make more input. We need also to understand the definition that we have got the alert phase where it becomes 10 to 20% of the cases rolling within the 7 days period. And then 20% and above, which is a resurgence, it's also, again, it must be on the 7 days moving average rolling period. And then afterwards, and then you get the fourth wave. At this stage, we are not on the fourth wave. We were in the alert, I think 2 days ago or so. We're waiting for another 3 days or so in order to say we are in the resurgence, but the HOD can confirm if we're in the resurgence or not. And also in regard to the variant, again, it's also still the data that is coming from when it initially from the Gauteng data, and then with a proxy using our samples in regard to the variant. Chair, lastly, it's not the first time that the health system, not only as the health system does actually give an information, share about the variants. We shared about the variants when we had the Delta, after the Beta, when we ended up pausing for providing AstraZeneca. We shared about the variants in regard to the Alpha, although it was a smaller number, which is the one that was picked up in the UK. We share the data, but we have got a fewer, some of the strains of the C.1.2, the variant, I think May 2021. So there might be a variance of interest, not necessarily the variance of concern. So we have shared that data already. So I just want to bring this so that there was something out there about why did we share this information as the health system, because it was shared after we had the meeting with the National Health Council, which is us as MECs and the HODs contributed. So we have always been open throughout in regard to the space. Where are we now in the Western Cape? The numbers, we see the numbers, we see the number of the cases and other metrics, for example, the positivity rate, the reproduction rate. At this stage, the deaths and also the hospitalization might not be, they might be minimal, and also the numbers might be, in terms of the quantity, they might not be as much, but you can see that we do pick up some of these number. Vaccination, just like the whole country where we have got this fatigue in terms of the vaccination, but that at least about 49% plus, we still lead in the province to have a large number of the adults, 18 plus older, who have been vaccinated, whether it's one J&J or it's one Pfizer. We are concerned, even as a country as a whole, that though we have got capacity, including the Western Cape, initially we said our capacity is 30,000 per day, which gets to about 200 per week. And then we said we can even increase to 40 to 60,000 per day. Unfortunately, we couldn't be able to reach that, but we still have got the capacity to give as much as we can. We still have got concern about the 50-year-olds group, specifically 50 to 59, where we'll find that there's still some number. We don't see the numbers increasing as much as we would like to. Generally, there are about 1.4 million of the 50-plus-year-olds in the Western Cape, and out of those, at least about 60% they've got the vaccines, but worried with those 220-something thousand. Again, lastly, we set ourselves up in regard to the capacity because we said ideally we would have wanted 85% of the over 50-year-olds to be vaccinated by the end of this year, and then the other age group to be 65%. Unfortunately, it hasn't been like that, which is a challenge throughout the country. However, we have done as much as we could in terms of the demand creation. We have seen pop-up sites in the malls. We've seen pop-up sites in the SASA. We've got the Vaxi Taxi where you just pitch up a tent, and also there's the EMS car that provides. We've seen where we've been dancing with the minstrels. I think we'll be dancing with them again Saturday somewhere in Cape Winelands. So we are doing as much as we can. Remember, again, it's about the health services, the healthcare workers are the last line of defense in regard to the response to the COVID. The first line of defense is within the community, is the prevention. The NPIs are there. Everybody will know that Auntie Sarah who's staying elsewhere, we might not know. Those ones that will know will already, especially those who are on chronic medication, we've already reached out for them. We're no longer now expecting people to clinic to health facilities to be able to get vaccination. We go to them. We've been in the clubs dancing with the youth as before, Joel. So that's why we appeal everyone, including us here in this room, as the constituency heads, where you know that there are people vaccinated, give us a shout because we won't be able to know everyone. Yesterday, I met with the universities because there might be a question about the mandatory vaccination. Met with the universities, which is they've been upfront and they've been open about the mandatory vaccinations. I met also with the higher health, who are looking in terms of the total health of the students throughout, not only for the universities. We've got 32 of the TVET colleges. We've got 22 of the community education and training centers. For me, these are the ones that you are worried about. So we're looking forward now, Chair, to answer your last question about the youth. We're looking forward specifically now during the open days in January, when we'll be assisting the higher education to make sure the first years get vaccinated, as we know that they are potentially the super spreaders. I'm talking about the younger persons. Dr. Kluti will talk about the 12 to 17-year-olds. Whilst it's important to vaccinate everyone, but for me, what keeps me to have sleepless nights is about the 50-plus-year-olds, because we do know age is a factor in regard to the risk factor into hospitalization and also the severe death. Over to you, Dr. Kluti. Thank you, Chair.
Thank you very much, Minister, for those opening remarks, comprehensive and a nice overview to get the meeting started. Good afternoon, Dr. Kluti. Nice to see you again. I'll hand straight over to you. Thank you.
Just to clarify, Chairperson, can you see the slides?
Yes, we can. Thank you.
Just clarify exactly the time period.
You have 45 minutes.
From now, or?
Yes.
Okay, thank you very much. So thank you very much and good afternoon to the committee. What I will be sharing with you today is just the surveillance and response update on COVID, also our fourth wave response plans, the current status of our health platform, and then the vaccine implementation update with some key messaging at the end. So just in terms of surveillance, we are tracking virtually on a daily basis what happens with COVID and all the metrics that we report on. So this is the integrated slide. And just to take you through it, you can see that we've now had 3 waves And right to the right-hand side, we're now starting to see an increase in cases. Although it is not a fourth wave yet, we have seen increase in cases. So case positivity, active cases, hospitalization, and oxygen use are the markers that we track on a day-to-day basis. So in terms of where we find ourselves now, the national trend is there now is steep increases in Gauteng, and actually every province, except in the Free State and in Northern Cape, there are now steep increases. So you'll see right to the right-hand side of every province, they've entered what is called an orange period. And if you look at the orange period, it's what is called sustained increase. It's now being experienced in every province, including the Western Cape, the right bottom one. So this is our picture, and this is literally an increase over the last 10 days. So we're now seeing clear increases in number of daily new cases, with an average of about 100 new cases per day. We were as low as 30 new cases a day about 10 days ago. It's now gone up to 100 new cases a day. The proportion positive has increased. It's now about 5.3. A couple of weeks ago, 10 days ago, it was as low as 3.1. Sorry, it's 5.1. And admissions are showing signs of possible early increase, but it's still very early days. Our admissions currently is about 10 admissions per day, and the deaths remain very low. We're only seeing 1 death a day, and we expect that to be a delayed thing anyway, so we're not expecting increase in admissions and deaths yet. So the metro overview is where the bulk of the increases in the last 10 days have been. So overall, there's about 111% week-on-week increase in the metro. Now, you must remember this comes off very low absolute numbers. So any increase gives you big percentages because the absolute numbers have been so small. Most sub-districts are starting to see these increases, particularly in the metro. It is northern, it is southern and western, and it's in Klipfontein, where we're seeing the big increases. When you go to rural areas, there's a less of an increase, but there's 2 areas, Garden Route and Cape Winelands, that are showing some significant increase as well, albeit of very low baseline numbers. Reproduction numbers are a very important one. It's something we track. And just to explain it again, a reproduction number of 1 means that there's no increase in the cases. That means 10 active cases gives you 10 new cases. When your reproductive number starts being where this one is now at 1.8, it tells you that 10 active cases produce 18 new cases. And that's how the reproduction number works. So we are in an accelerated increase of cases phase. So this is the point that Minister Mbombo was referring to. We formally now, week on week, percent increase in what we call the 7-day moving average of new cases has now been more than 20% for more than a week, which now indicates that we're formally in a resurgence. The definition to the right-hand side, a resurgence is above 20%, sustained for 7 consecutive days is considered a resurgence. And you can see at the bottom, the red bars, that's what we've now seen from the 21st of November all the way to the 28th of November. If you then look at the short-term predictions from the South African COVID Modeling Consortium, they show now a rapid increase. So we see we have very low cases. The dotted cases is our real cases versus the gray line is the predicted cases. Because of this increase in cases, they're now predicting quite a significant increase in cases based on the experience of what has been seen in Gauteng. And this is an update on Omicron in the Western Cape. So what you see here is, if we look at the left, that was when beta towards the purple line is when beta was predominant. In June, Delta became predominant. And what we're now seeing in October, we're seeing that this Omicron has now emerged very quickly in September. And towards November, it's obviously been picked up now. And as the rapid emergence of Omicron is now 68% of samples in South Africa by the 21st of November. More than 60% of the specimens in last week that we have here of what is called the PCR marker for Omicron. So I just want to explain the difference. The gene sequencing in the lab is you go through and it's about 2 weeks when you confirm those cases. So we've had 15 gene sequence confirmed cases in Omicron by yesterday. But this Omicron has got its characteristic. There's a specific PCR test. It's called the S gene deletion. And on that test, it's a marker of all the specimens we took last week in this province. 60% of them has this proxy marker for Omicron. So it's safe to say, as the sequencing catches up, the majority of the cases we currently see in the Western Cape is driven by Omicron. Just to give you a sense of where the 242 sequence cases currently is, it's in 21 countries already. Cases in some countries without travel history or recent contact travel suggest the possible community transmission, which basically means that this is probably established across the world already. It just has not been detected. So what do we know about Omicron? In terms of transmissibility, the scientists are still tracking to see whether it is more transmissible than Delta or Beta. So when the evidence emerges, and we expect it to emerge over the next 7 to 10 days, we will then say what we know about transmissibility. Risk of reinfection, there is some evidence of a reinfection risk, but we're not so sure is the protection versus severe disease maintained. So we don't know what that reinfection means in total in terms of the severe disease protection. Disease severity, there's no early signal to suggest that people are any more severely ill because of Omicron. Again, the science must emerge. Diagnostics, the tests all appear to work. As you can see from what we have, we can detect early. The sequencing take a while, but now we can, with the PCR assay, we can quickly pick up the S deletion, which give you a rapid sense of how this is progressing. And then the big question everybody has is about vaccines. Again, the protection against severe disease should be maintained, at least partially. That's what we know at the moment. So there's no suggestion to suggest that vaccines will not protect against this Omicron. So that's why the big message out of all of this is people that's not vaccinated should get vaccinated to protect them against severe outcomes. The clinical disease severity, the admission numbers in Gauteng have increased now steeply as well. And the admissions have now been keeping with their steep increase in case numbers. There's no evidence yet that Omicron causes more severe disease, even from Gauteng picture. There are reports of more young people and children being admitted, but this may be due to the fact that these groups being less likely to be vaccinated. And they've also been involved in events where the virus was spread. So we obviously need to watch and to assess carefully to make a assessment of that. That brings us to the COVID-19 fourth wave response. The possible fourth wave scenarios before the variant was identified. There was a discussion about we must make some assumptions about seroprevalence. That means your previous infection and now what the antibody levels are. The presence or emergence of variants, and we've now seen in the last 10 days that there was a new variant that emerged, not just here, but globally. Assumption about admissions, assumption about excess deaths, vaccination, and the vaccine coverage. The assumption here in these consortium scenarios is a 70% coverage by March versus the 42% current, and then the vaccine effectiveness as against published data, and then also effectiveness is maintained against hospitalization. There were two quite severe scenarios that they came up with. The one is that the behavior post-third wave, there's no response, and therefore there's an increase in the fourth wave. And the second scenario has actually come true, which is this one, that there will be a variant where reinfections will happen because some immunity doesn't protect against the reinfection with the new variant. So this second scenario is currently being reworked into different scenarios. Assumption that it's a 25% immune escape with a risk of reinfection versus 50% immune escape with the risk of reinfection. Now, all of those are projections, but it's being worked. And based on that, we are currently being advised to plan for at least what we did in the third wave. The big assumption is vaccines still remain effective against severe disease. And if there is behavior response, we can still blunt the curve even of the fourth wave if people stick to the key behaviors, which I will come to later. So based on that, this is our fourth wave resurgence plan. It's a 6-point plan. Firstly, sustainable and affordable interventions based on current evidence. What do I mean by that? The evidence is the biggest protection against COVID now, there are 3 things we need to do. The first one is get vaccinated. The second one, wear a mask, especially if you're going to be indoors. The third one is preferably use fresh air. That means ventilation in buildings indoors, open the windows, encourage people to use fresh air and flow through indoors settings, and then preferably be outdoors in terms of fresh ventilation. So the evidence says if we stick to those 3 things strictly, we will be able to prevent rapid spread of the COVID, of the Omicron variant. The second thing is surveillance. We now shift our indicators of the health service pressure, and we need these reliable indicators for health service pressure so that we can pick up the first moment there's a sign of the health system pressure picking up, so that we can actually keep a very close eye and titrate our response accordingly. The third big thing is support and maintain the mass vaccination. So this is also a time to step up vaccination because it remains a key intervention to mitigate the impact of the 4th wave. The 5th intervention is then titrating our health platform capacity, and that is the surveillance that I spoke about in point 2 guides us when do we bring what capacity online to be able to cope with the numbers as they come. The 5th point is to maintain some level of comprehensive health service. So the de-escalation of services hampers the provision of other services. We've seen after the 3rd wave, mental health, chronic disease, TB, HIV, immunizations, all of those things, cancer care, they all have been affected by 3 waves of de-escalation. We have to mitigate this cumulative negative impact on all these conditions by maintaining some level of comprehensive service during the 4th wave. And then the last one, a 6th point for us, very important pillar for us, is to safeguard the well-being of healthcare workers, because our entire plan premises on sufficient healthcare workers being around to be able to cope with what's coming at us. So therefore, vaccination, and especially the booster doses under Sisonke, is then a key intervention so that all our healthcare workers are maximally protected going into the 4th wave. But also for us, we've started and we are maintaining the healing process for healthcare workers, and also looking at their mental well-being in terms of employee support. So this is our triggered response for the 4th wave. From the 3rd wave, we shared this with the committee before. There's a level 1, or what we call a first tier, first warning trigger set, then a 2nd tier, then a 3rd tier, then a 4th tier. So what we're saying now in the 1st tier, we are going and looking at oxygen use as a key driver. I'll explain why we're using oxygen use. We went back to the 1st, to the 2nd and the 3rd wave, and it's a very sensitive marker. If there's this 50% increase in oxygen use, that's the first marker to say to you, bring more capacity online. So we're tracking our oxygen use very carefully, and it's a very sensitive marker. When it comes to the 2nd warning, we will look at this thing called a 10% week-on-week increase in the 7-day moving average for new admissions. Also a very sensitive marker. We went back and we tracked that with the 2nd and the 3rd wave. And if we had used that marker, we would have escalated our additional capacity quite early on in preparation for where we need to be. And in addition to that, the 75% pre-COVID oxygen use for 3 days at least. Those 2 triggers together, that triggers our 2nd level of interventions. Then the 3rd warning is when our high care ICU, high flow nasal COVID oxygen beds, more than 50% of those are occupied. That's quite a sensitive measure. And we have more 100% increase of the pre-COVID oxygen use. We use those together, and that's the last warning sign to say our entire health service capacity now is under threat. And that's where we need to look at the high markers at the peak of maintaining what we need to be able to do to make sure that we cope with the peak. This is what we will do for the 1st level warning. What acute capacity bed do we bring online? What critical care capacity do we bring online? What intermediate care capacity, referral pathways, ambulance service, and oxygen? Now, we have not even triggered those things yet, but we're already starting all of those preparation already. For instance, on the oxygen, we have already worked with AFROX. We're putting additional oxygen tanks in. We are connecting some concentrators. Ambulances, we've already agreed with the private EMS guys. They will come online. The referral pathways, we're starting to look at it already. The moment there's a lot of pressure on any given site, we will start moving. So we've already started escalating some of this. But you'll see in a very systematic way, we then go in a triggered way, like we did in the third wave. So what's our current status of the health platform? Our bed occupancy currently is at 90% for metro hospitals. The George drainage area is at 72, Paarl 75, and Worcester 76. Our critical care bed occupancy for designated COVID beds is only at around 10%. And our COVID and PUI cases currently only make up 3% of all our acute capacity. So the hospitals, I have not really seen a massive increase in COVID yet. We're still at the low numbers. The intermediate care, the Brackengate Hospital, only has 7 patients. We've kept Brackengate open. Soornstraal and Paarl currently has no patients. Frisia and Ward 99 at Lentegeur, no patients. And the Mrs. Plain Hospital Hope has been closed, but we are putting plans in place to also bring it online as the triggers come in. So we're putting plans in place to do that. The Metro Mass Fatality Center has also closed, and we have to work with our colleagues across all the municipalities to see whether the funeral parlors and the undertaker capacity is sufficient to cope with this 4th wave. And that team is actually escalating and re-escalated and starting this Friday to put their plans in place in light of the increased cases. So this is our daily dashboard. This is where we track the occupancy of beds every day at 1 o'clock. And you can see that's very sensitive. We can pick it up on a day-to-day basis. These are the things that we use for our triggers. This is just to bring you up to speed with what has happened with trauma cases. And we've been tracking this all the way from the first wave. So you can see over the last 8 weeks, since the start of alert level 1, we have seen a total of 22,694 trauma cases at 20 of our emergency centers where we're doing this data tracking. This is about 2,943 additional cases over the last week alone. So over the last week, we've seen that additional 2,900 cases. These trauma presentations continue with this weekend pattern of violence and trauma, and further worsening after a payday or end of month weekend, likely secondary to the increased alcohol sale during this period. So the last end of month weekend saw a total of 1,410 trauma cases from Friday through to Sunday. So we track this very carefully. This is preparing our people capacity for the 4th wave. We currently have appointed 863 staff additional for COVID. Their contracts have now been extended till the end of March. We also have 1,471 healthcare workers and support staff, which includes 603 interns for the vaccine drive. And we still have a total of 803 applicants that can still be appointed if we need to. So we're carefully watching what the numbers with our staff is. Vaccination training and vaccinators, that's also doing well. And obviously encouraging our staff all to be vaccinated is a key thing. And then, as I said, the staff well-being and the resilience, that is still being tracked. We've also provided leave provisions, and we did a thank you from myself as the HOD accounting officer. We gave every staff member in our department 2 days leave in recognition for everything that they've done up to now. And that 2 days leave was meant to be up until tomorrow. So it was taken between September and the end of November. So every staff member in the health department should have by now have taken their 2 days leave in the 3-month period between the waves. So this is also how we track our infections amongst healthcare workers. We can see now, again, an increase is starting to happen. There's currently active 28 active cases for healthcare workers. It brings me to the vaccine implementation program. Our current aim very clearly is driven by 3 key imperatives. The first one is we need to promote equity. And the big issue here is we can't leave anybody behind. We need to increase access to registration and vaccination sites. We need community level interventions. We need to target identified geographic areas because everybody that needs vaccination should be vaccinated. The second big focus area is demand creation. And that's really to retain this focus on the 50-year plus group because they're the most vulnerable. And we want them to be fully vaccinated as maximum protection for the 4th wave. We also need to continue to neutralize misinformation and strengthen the pro-vaccine trusted voices. We have also been working very closely with both business, government, and civil society with specific daily targets in terms of mobilization. Then the big thing is our targeted approach. It's really focused on geographic areas with a low vaccine uptake, maximize the reach and efficiencies through increased outreach and pop-up sites, and then rationalize and retain fixed sites with high throughput where appropriately placed. So it's really about moving to a model where we have a combination of some fixed sites where people can come to get vaccinated, but we've seen those numbers drop. And what we're doing now is we're putting much more agile and outreach systems in place to go to people, to bring it closer to where they are through mobiles and pop-up sites. So this is the vaccinations as of yesterday, including your 12 to 17-year-olds. So the national adults fully vaccinated yesterday was 35.9%. In the Western Cape, we're standing at 42.70%. As the minister said, this is the highest for the country. The vaccination in the Western Cape to date is 4.1 million vaccines have been administered. In the last 24 hours, we've done 22,800 vaccinations. You can see the cumulative vaccines, where we started off all the way in May and where we get to our 4.1 million administered now. The bottom graph is the one where we've been trying to maintain a target of 200,000 per week. You can see the numbers per week has gradually dwindled as the interest has dropped of people presenting. And last week, for the first time in a very long time, we did less than 100,000 people per week. And that is ever since we started tracking this, which is around about from the second week in June. So obviously we want this to be as close to 200,000 as possible. Well, at least in the first 2 days of this week, we've seen an increase. So based on the first 2 days of this week, it seems that we will be above 120,000 again for this week. So that's the projection for this week. So our current status then, as of yesterday, we can see that although 2.4 million people have been vaccinated, that's roughly 50%, and 2.1 million, which is 43%, is fully vaccinated. We can see that 2.5 million people are unvaccinated still, and that breakdown is 220,000 over the age of 60, 270,000 between the ages of 50 and 59. Obviously, more people under the age between 35 and 49, and then 18 to 34. Our big concern is those two groups, over 60 and 50 to 59, and that's what we're targeting. So the registration breakdown, so as of yesterday, we had 2.6 million people have registered. So it's about almost 46.9% of the total eligible population. And you can also see in the age groups what that is. So in the over 60s, 72% of people have registered, and 50 to 59, it's closing in on 60%. The other age groups is obviously lower, and you can see 12 to 17, only 12% of 12 to 17-year-olds have registered to date. If you look at the proportions in the geographic areas of everybody over 18 registered, you can see that a place like Western in a metro, almost 80% of everyone over 18 has registered. If you look at the place like Overberg, it is 61%, Garden Route 52, Cape Winelands 53. But the areas of concern for us, Khayelitsha, it's only 33.2%, Klipfontein 49.9%, almost 50%, Mitchells Plain 30.9%, and Tygerberg 46.1%, and then Central Karoo 41%. So you can see the areas where the registrations are lower as compared to the other areas. So this is the vaccinations for over 60s and then 50 to 59. So that's where the picture we said to you, partially proportion fully vaccinated, over 60, 65%. And you can see the proportion, the areas where we need to focus for over 60s is Central Karoo, Khayelitsha, and Mitchells Plain. If we go in there, we find more people, we can push this number up. If you go to 50 to 59, 54% fully vaccinated, the areas is Central Karoo, Khayelitsha, Mitchells Plain, and then also Tygerberg sub-district. So this is just a breakdown of over 50 fully vaccinated. You can see Overberg leads by far, 74% of people in Overberg. West Coast 58%, Cape Winelands 58%, and Central Karoo, Garden Route 65%. The metro overall is 55.7, but in there lies Khayelitsha, Mitchells Plain quite low, Western and Southern quite high, and in Central Karoo 43%. So the big area of concern for us in terms of equity, when we look at this figure, that gives us impetus for our targeted intervention. So currently over the age of 50, if somebody is insured, that means if you got a medical aid and you're in the Western Cape, 95.8% of people that has a medical insurance in this province is currently fully vaccinated if they're over 50. But only 47.1% is fully vaccinated if they have no medical insurance. And that's the majority of people that has no medical insurance. So our provincial targets up to December, we are entering December today, and you will see that. So you can see that we were trying to say that we need to get to 85% of people over the age of 50, 18 to 49, at least 65% for one dose. You can see the number of vaccines we still had to administer to get there. 643,000 vaccines for plus 50s, 762 for 18 to 49-year-olds. So whatever days and weeks are left of December now, each day counts, because we need to find as many new people that's unvaccinated to be reached in this period of time as the fourth wave starts taking hold in our setting. Sisonke is the booster doses for healthcare workers. You can see in this province, we have done 43,516. Obviously, we have much fewer healthcare workers than Gauteng. So per healthcare worker, this province also has administered the most booster doses. But what we're also doing is we're now encouraging additional healthcare workers to all come forward before the 16th of December. So we're expecting this number to increase over the next week or so, a new week to 10 days, so that we can get to as close as possible that every healthcare worker has got their second dose. If healthcare workers opt out of Sisonke, as well as healthcare workers which were vaccinated with J&J after the 17th of May, they will be able to access a Pfizer dose, but that is still subject to nationally necessary approvals from SAPRA and from the National Department. So that has not been it's not opened yet. So we're encouraging all healthcare workers not to wait for the Pfizer dose, but take the J&J dose. That's on offer. You will be getting protection. The science is saying you will be protected. So our remarks on vaccine implementation generally is that as a province and a country, we are unlikely to hit the targets we have set, despite having the capacity in the vaccine supply to do so. The value of the national incentive, there's also been this voucher system for people aged 50 years and older. That's now increased from 100 Rand to 200 Rand for everybody that comes and presents themselves to be vaccinated. So it's an incentive. So because the value has gone up and the system has also been done slightly easier, we hope that this incentive is an additional incentive for the over 50-year-olds to get people to be vaccinated. The primary focus remains on ensuring that the most vulnerable groups, especially people over the age of 50 and people over 18 with comorbidities, are targeted. Now, just to explain about the booster doses, there was a question about booster doses. So the first set of booster doses starts today, and that is for immunocompromised people. So these are people that have had 2 Pfizer doses already, and they now qualify for a third Pfizer dose from today. But these are people with rare immunocompromised conditions. They need to come with a letter from their doctor to say that they suffer from that condition, and the system from today are starting to deal with them, and they are, at this point in time, the most compromised people, and we're starting that today. In terms of the general booster doses, for everybody over the age of 50, the general population, as Minister Mbombo said, the time period for that only kicks in from about the first week in January, when most of our people will be 6 months beyond their second dose of Pfizer. Obviously, in the next coming weeks, we expect all the processes to be finalized with SAPRA and the National Department, and we will announce the appropriate date when booster doses generally are available, but the expectation is that it is imminent and it will be soon. So ensuring equity and access is still our ongoing efforts to remove all barriers to ensure that we have good access, and then our targeted mobilization, that's reaching everyone that's not got around to it, as well as those that are still unsure and anxious. So I will just end up with a few key messages that we then do there. The first thing is the vaccine access. So we're promoting site access and locations, central and local areas, for people that have not got around to being vaccinated yet. So we're trying to advertise very clearly where the weekly sites are, where the weekend sites are, and also the daily pop-up sites for each geographic area. The vaccine access pop-up sites, you see that Vaxi Taxi, that's an EMS vehicle. You can see that's happening in the Free Zone end, and it's basically 2 EMS vehicles pulling up, canopy in between, and wherever they stop, wherever they pull, that becomes a vaccine site. You can see a pop-up site in Khayelitsha Mall. You can see a pop-up site outside the Mfuleni car wash. You can see a pop-up site between buildings in Freedom Park, in Samora Library, at the Bella Airport Mall. So you can see all of these are in areas where we target with low uptake. So it is low uptake areas where we're taking the vaccination closer to where people live. Another one is vaccine hesitancy. So our outreaches also is addressing the genuine concerns, and we have this face-to-face access to information. So we have this program called Ask a Doctor, and the Ask a Doctor has been in Mitchell's Plain. It's also now been in Khayelitsha, and over this past weekend in Khayelitsha, 420 people talked to doctors, private and public sector doctors, made themselves available at convenient places and asked the person, do you have any questions for us? Do you want to discuss vaccines? We are here. Ask us. We're a doctor. We can tell you what the facts are. And then also in the Delft Mall and in Tafelsig, it's these outreaches. So our fourth wave risk mitigation, it's really the vulnerables. I think that grocery vouchers is now extended to over 50s, and as I said, it's 100. But the big thing that we are saying, which the science takes us to for saving our summer, is vaccination is the key thing. The second thing is wear a mask, even if you are vaccinated. And the third thing is ensure open windows, fresh air, good ventilation, and where possible, meet with people outdoors. That's the science, that's the message that all of us need to adhere to. So in conclusion, we are seeing the early signs of an increase in cases that could start heralding that a fourth wave is inevitable in our setting. We urge everyone to adhere to the protective behaviors, get vaccinated, wear a mask when you're indoors, seek for good ventilation, and be with people, preferably outdoors. And contain this over the coming days and weeks in expectation of this fourth wave. We have this tailored stepwise health and societal response, and we will trigger them appropriately to detect and mitigate the impact of the fourth wave. Our biggest weapon remains vaccination, especially for over 50-year-olds. We have the capacity, but we now require everybody to come forward and to assist us. We need to scale up our multi-sectoral mobilization effort to reach everyone that's not been vaccinated in a targeted and intentional manner as fast as possible, to be able to restore our economy, to normalize the health system and societal functioning in general. That's the appeal we make to everyone. Thank you very much, Chairperson.
Thank you very much, Dr. Kuti, for the presentation and for all the detail that you've provided as per our request. Yes, quite a situation. I'm sure the members have a number of questions for you. We're going to proceed in the usual manner. I'll be asking each political party if they have any questions that they would like to pose. And of course, each party will then get the usual 3 minutes for the first round. I'm going to start with the DA, and I see Honourable Philander. Sorry, Honourable Philander, I see there's a hand from Honourable Dugmore. Is that a point of order? No, apparently not.
It's not a point of order, Chair. It's a request to speak, to ask a question.
Yes, you'll have your turn. All right, Honourable Philander, over to you.
Thank you very much, Chair, and thank you very much to the Minister and Dr. Klute for that very detailed and extensive presentation. Chairperson, my first question. The Minister as well as the Department embarked on various innovative interventions of really getting vaccines to the public. One can cite various examples, the drive-through facilities, how the hospitality industry were accommodated, the nightclubs, as the Minister made mention of, and the taxi ranks and so forth. Chairperson, my question is, have these innovations proven to be successful? And what is the indicators presented thereof? Chairperson, then my second question, along with the weekly digital broadcast, the radio broadcast, print media, the website, the dashboard, all of those that provides information to all residents across the province in order for them to also respond to, or rather to track the response to the pandemic, and as well as the safety and the efficiency of the vaccine. What else does the department plan to address the slow uptake, and in the same manner, vaccine hesitancy. Of course, I also note and welcome the Western Cape's fourth wave resurgence plan as indicated on slide 22. That also covers various key interventions. My third question, Chairperson, the Premier during his address to the ad hoc committee, I think it was during September, mentioned that the province's communication strategy had been informed by various medical experts, and also today was focused, or rather emphasis what was made on slide 28 in terms of the strategic focus. Chairperson, would the department support the oversight body of the Western Cape Provincial Parliament to also embark on a targeted approach of engagement to specific communities that now indicate slow uptake and, of course, also vaccine hesitancy? Chairperson, my fourth question, in the light of the President's announcement this past Sunday, the government will also now, national government will also now set up a task team and the possibility of making vaccine mandatory for specific activities and locations, and make then accordingly subsequent recommendations to be tabled at national government. What is the Western Cape government stance on that indication provided by the President on Sunday? And then my last question for this round, Chairperson.
Okay, briefly, your 3 minutes is up.
Yes, indication was given about the 50-year and older age group, as well as what the provincial target was for December. So, yes, I think I'm covered with that one. As Dr. Klute, yes, in his address also made mention to the status update on that target. That is my question for this round. Thank you, Chair.
Thank you very much, Honourable Philander, for those questions. I'll now move then to the next political party, which is the ANC. I'll now recognise you, Honourable Dugmore. Over to you.
Thank you very much, Chair, and also officials and fellow members. Chair, I would like, and I think it was part of the question that Honourable Philander asked, to check with both the MEC as well as the HOD whether the provincial government supports the issue of mandatory vaccination. I understand, and maybe they could also just explain that term exactly, because my understanding of mandatory means that, for instance, to gain access to workplaces or public places, one would actually have to show proof of vaccination. So, and that then links to my second question. I mean, you know, one looks at the number of people vaccinated in our province so far, and also commends the fact that 42% have been vaccinated. But it's clear, you know, both from the presentation as well as the speech by the President, that the fact that such a low percentage of our people nationally and in this province have vaccinated poses a greater risk, because all the information provided so far in regard to dealing, say, for instance, with a new variant, having been vaccinated increases one's chances of not getting sick, even despite contracting the new variant, or avoiding being in hospital. And then in the presentation, Dr. Klute goes on to say that it's possible to vaccinate 40,000 a day, and we see pictures of, you know, this, but what we don't see is an actual target. You know, if one says it's possible to vaccinate 40,000 a day, that's very different from having a target. Because if you have low vaccination in a Khayelitsha or a Rafifs on Ent or whatever, surely the department must be setting actual targets to say that we want to increase the vaccinations in this community by so much in a week. So what I would just like to ask Dr. Klute is, what is the overall vaccination target in the province? Is it 80%? Is it 90%? And then what is the actual plan with weekly targets to reach that? Because it's one thing to set up a pop-up somewhere, but what is the target for a pop-up going up in Delft, for that particular day. So my concern is there doesn't appear to be a provincial target, and there doesn't appear to be a practical plan to actually reach that number. One is hoping for people to come to a pop-up, but if there was a more concerted target with healthcare workers moving into a particular area and saying, we're trying to reach 2,000 more people in this part of Blue Downs, for instance, and that's what we're going to do. So I would like to actually see what is the target and what is the weekly plan to reach those targets. Thanks.
Thank you very much, Honourable Dugmore. There's no representative from the EFF today. I now recognise the Good Party.
Thank you, Chairperson. Chairperson, thank you to Dr.
Honourable Heron, you seem to be on mute.
Sorry. Can you hear me now?
Yes.
Thank you, Chair. My question, I think, is maybe to MEC or Minister Mbombo. Both she and HOD Cloete spoke about the capacity to vaccinate more people in our province, but that we're not reaching those numbers because people are not showing up for vaccinations. And I also want to ask about the vaccine mandate. I think, first of all, has there been any decision or discussions, or are there any plans for a vaccine mandate for the province's own employees? And what about members of the provincial parliament? Is there a proposal or a plan that there should be a vaccine mandate for members of the provincial parliament? We've seen in other parts of the world that vaccine mandates have substantially increased vaccination coverage. And even in South Africa, Discovery Health, for example, have reported that when they introduced a vaccine mandate for their employees, the vaccination rate went up from about 20% of their employees to 96% of their employees in just 3 months. So why are we delaying, if we are delaying, implementing a vaccine mandate for our own employees of the Western Cape government? And what plans are in place for the Western Cape Provincial Health Department to implement a vaccine mandate for perhaps venues like restaurants and places of entertainment within the province, given the powers that the Western Cape Provincial Health Department has in terms of the National Health Act? Clearly, we need to increase the number of people who are vaccinated. And persuasion and communication has not been effective. And I think it is time that we look at a vaccine mandate. And I'm asking the Minister and maybe the HOD what plans, if any, they have to implement a vaccine mandate in the province using the powers that they have. My second question to the MEC is regarding a comment that the Premier made earlier this week when he said that there is no vaccine hesitancy in the province, but there is a problem with access to the vaccine. I found that quite surprising. I mean, the Provincial Health Department has the obligation to make vaccine sites accessible. So why is the Premier on the radio saying that there is no vaccine hesitancy, but he thinks the problem is a lack of access? And how are we addressing this lack of access? Are we taking vaccinations to people who are unable to reach vaccination sites? Thank you.
Thank you, Honourable Heron. Next, I'll recognise the ACDP.
Thank you, Chairperson, and thank you for the presentation. Chairperson, just a few comments and questions. Dr. Cloete has said that in order to prevent the rapid spread of this new variant, you must be vaccinated, wear mask, and also be in fresh air. My question is, nowhere do they speak about, other ways. He has not spoken about. We heard so many stories of.
I'm sorry, man. We're just in a ad hoc committee. It's still going on, but I thought I must call you back.
Order.
I have muted Honourable Dugmore. Apologies, Honourable Christians, please proceed.
Thank you. Just a question. Nowhere does the department promote immune boosters or ivermectin and those. What is the department's stance on immune boosters, ivermectin, zinc, and those type of things? The other question I also want to ask is, you know, we hear that this Omicron is not that severe. It lasts for 2 days, and you know, it's like a normal cold. If I can get more details on that, and also now with people taking the Johnson & Johnson vaccine and also the other vaccine, the question is, why do people now require the booster? And there's also now been said that Omicron, the vaccines that people have, that Omicron, you need another vaccine in order, because this is a new variant. You're not foolproof to this. So there's a lot of questions about this, that the variant is not so severe, and also that you are, even if you're vaccinated, and it was said that that's a percentage of people that will still be infected when it comes to this. Just from my point of view again, what is, and I heard some of the speakers speak about a mandatory vaccination. What is the definition, and is it that people, workplace, and those people that don't have a passport will not be able to go to work, and what happens to those people that do not want to be vaccinated? Thank you, Chairperson.
Thank you, Honourable Christians. And then I recognise the Freedom Front Plus.
Thank you very much, Chair Lady. Doctor, I never doubt your intellect, and I don't doubt also how much work you've put into fighting this pandemic. But what is the bold plan here? What's going on? Let's look at not at South Africa only. You have an engineered virus, engineered, of course. And we all know it's been engineered. It's not a natural virus. And the vaccine is not a vaccine as well, because vaccines are dead viruses that they put in your body. This is not a vaccine. This is engineering at work. And I want your view on this, because it's actually a toxin. This, what they are putting in, this, what do they call it? Spike protein. Can you explain to us in layman's terms what constitutes a spike protein? And how does a spike protein affect people who's got comorbidities? I mean, people who have diabetes or heart problems or that, doesn't it exacerbate it? Can you be sure it doesn't make it worse? Isn't that why we were told by you that people with comorbidities like diabetes, most of the deaths come from that people with such preconditions? So what have we got here? What's going on? You take years to create a vaccine that can be administered. Every time there's a new type of virus emanating from the original one, what do you give the people? A concoction of all the other vaccines? Or how come you can make a vaccine for the new strain so quickly, within weeks? I'm baffled. I mean, I have been twice, MEC for Health in the Western Cape. I've never seen anything like it. I also read up that more people die every minute of starvation and hunger than what people die of COVID. Oxfam in India reported this. 11 people die every minute in the world from hunger and starvation, and they say there's no money. Even the United Nations, WHO say there's no money to feed all the people, but all of a sudden there's billions to provide us with all sorts of vaccines. I just want to know, do you every time find a new vaccine for new variants? Or where does this vaccine come from that will now address the new variant? And why the scare tactics, doctor? I read the Sunday Times and a lot of people phoned me and said, what's going on? They said 10,000 people expected to be infected every day now. Now you've just told us, no, it didn't come about. It's not so. Our hospitals, very small percentage in our hospitals in Brackengate is there because of COVID. That is my first question. Thank you.
Thank you, Honourable Marie. Your time has expired. And then see Honourable Brenkhase. I know you're not a member of the committee, but would you like to pose a question?
Yes, thank you very much, Chair. Chair, my question is to the department, Dr. Kluti. Dr. Kluti, many of us have, in the previous waves, in the second wave, in the third wave, gone very, very sick. And we experienced a lot of very bad symptoms with this so-called coronavirus. And the symptoms, it varied from, you know, a lot of tiredness, a very deep fever, and many other symptoms. My question is that this upcoming fourth wave that everybody's talking about, I believe a lot of people in the Gauteng province have already experienced this new variant, Omicron. Can you maybe share with us the kind of symptoms that the people are experiencing in this with this new variant, so that I mean, many of us that have experienced this virus, you know, we will never forget that experience. So if you can maybe share with us that what are some of the symptoms and the experiences are that the people are going through in this with this new variant, so that we can also maybe prepare ourselves better if we have to get sick in this upcoming fourth wave. Thank you very much, Chair.
Thank you, Honourable Brenkhase. That then concludes the first round of questions. I'll hand over to the Minister and the HOD for response. Thank you.
Thank you, Chair. I will answer some, and then Dr. Kluti can add, or other colleagues from Health and add some other response. Thank you for the questions. I think I'll start from the last ones, whilst they are still fresh, and then go up to the first ones, but not all of them. Member Brenkhase, I think HOD will explain that with the COVID, when it started, the whole issue about the flu, hence there was even introduction of having all these thermometers when you enter, because it was associated with such. As it evolves, because we once keep on presenting about how the virus evolves and ended up being a variant. You find that now some other people are not even symptomatic, especially with the young ones. Whilst others, the symptom might be only just a loss of smell, or even a loss of taste, without having any other symptoms. So it becomes quite complicated. Whilst others, they will have the whole of the cocktail of the symptoms. So it is difficult to put it there that these are the kind of symptoms. But what I know for sure is that there is a time where we find that we question the use even of those thermometers when you enter. Similar that at the time, the issue of the obsession in terms of the surface cleaning and even scrapping all these things from the grocery shop. At the time, it was only based on the aerosolization, which is only about the droplets, and then they collect and then they can drop on the floor. If you recall, even at the shops that you have those separators, but now it's in the air. So you could be in one room, you might be 1.5 meters, but if there's no ventilation, you can still breathing that COVID, although you might have been 1.5 meters apart. But if it's a small room, the poor ventilation, you could actually get the COVID. So it's quite complicated. With the Omicron, it's still early to determine exactly what. In as much as that I saw from the SAMA, South African Medical associations, when two of the doctors were talking about some of the clients they've seen in their surgeries, about that it's a mild. At this stage, it's still too early because it might be those ones were young people, so it's still too early to determine around that. Taking note as well that people now, some people are vaccinated, so you may get infected being vaccinated, but you may end up not having severe symptoms compared with others they might have such. So it's complicated. Member Murray, I know you don't like to ask questions from me, but I'll respond anyway. But I just want to put it like that. I don't know what is in Panado. I don't know, but we still prescribe Panado for the headache. And if you look at the pack of a Panado, he does talk about the severe form, especially when they say that don't use for more than 10 days without consulting your doctor. Where in some cases you can even have a coma or whatever induced, something like that. What I know for sure, also I don't know what is in the diabetes treatment. Diabetes is one of our major conditions in the Western Cape, especially among the females. We give insulins, we give oral diabetic treatment. What I know is that it does save people and reduce complications. And nobody has ever queried in terms of that, what is it in that diabetic treatment. Similar with a hypertensive treatment. We've got people who are on hypertension and we give it to them, and it has never been where we have to explain and query and all of those, what is the ingredients. Today is World AIDS Day, where we are talking about the second 90, which is about where people have to take the ARTs, the ARVs, and they've been taking the ARVs for long, and then we've got now even the one pill one can take, irrespective of whether you are HIV or not. We have never received so much of the criticism around that. What I know for COVID, when you have got the complications, when you enter there in the hospital, when they give you oxygen, nobody queries what is in this oxygen. Put it in the high flow way, it just goes into your nostrils, and actually you want to even to have more of it for that oxygen without even querying it. When they give you the steroids, the dexamethasone, where also even some of the cocktails of antibiotics and everything, nobody queries. All you want is about to be saved. When you put all those tubes in theater, I mean in ICU and everything, nobody queries those. So what I know is about the benefits of the vaccinations outweighs everything else. So that's why you have to choose vaccinate or you ventilate. And you unfortunately won't even have a choice at the time that the ambulance comes and fetches you, and then you go there. You'll never be able to say that I don't want the oxygen, you don't want, etc., etc. Dr. Kruger can give more information in terms of what is the ingredients between the mRNA vaccines or the vector ones. Now, in regard to ACDP, in regard to the boosters, when I started speaking, I spoke about the immunosuppressed individuals now that they could be able to get an additional dose. I don't put it as a booster because it's about when you are immunosuppressed, the duration of the efficacy or duration of the vaccines, they might actually disappear quickly from your body. So that's why there's an interval where, like if you've got AIDS with a 200 and lesser CD count, when you've got your cancer patient and all of those, where now you could be able to get additional doses. With the booster doses, again, to make it an example, some of us who are children, have got children, and we know that we have to immunize your child. From birth, you get the polio, you get the BCG. 6 weeks, repeat polio, and then you've got the diphtheria, the tetanus, and all of those. 10 weeks, repeat, same thing. 6 months, measles. 9 months, measles. There was no measles. There was only one measles before at the time that some of us were practicing. And then you get all of these at 12 months, 18 months. All of these immunizations that I'm mentioning, they are booster. Some of them are booster doses, whether it's for hepatitis, whether it's for pneumonia, whether it's for diarrhea. So there's always been a booster dose. Now, currently for adults, for the yellow fever, when you go to these African countries where you have to have yellow fever, I think it takes 9 years, because I just checked mine that my yellow card for yellow fever, it has expired if I have to travel to these countries with a yellow fever in Africa, meaning that I have to have another one. But with a flu vaccine, with a flu jab that we get annually, every year you have to go for another flu vaccine. So it becomes annual. So similar with the issue about now with these vaccines, there's nothing wrong to have a booster dose. Noting COVID is new, it means that there will always be a new data that's keep on coming. Like with the J&J, where it was found that one dose is enough. But remember, there are variants that are keep on coming now and again. And it is typically a virus will always keep on evolve so that it wants to run away. Once it's being known, being familiar, it runs away. So it comes up with different heads and faces. So therefore, as I made an example earlier, that when we had the beta, we were ready to give the AstraZeneca, and then it was said, no. Now we've got the Delta, take those vaccines, go and sell them, have something else. Similar with the J&J, with the Pfizer, it says 2 doses, and now it says that we need the booster dose. Where the country is, it's about, at least to start again, the issue of the equity. We started with the healthcare workers, those who have been part of the Sisonge, who's going to do the J&J. Sometime it will be open for any others who are not necessarily part of the Sisonge, and they can choose whether they want to do the J&J or they can choose to have a Pfizer. And then with the older persons, because we started with them as part of the public, plus also there's the school teachers, the teachers, the other civil servants, the social department, and all of those who have been always, we started with them. So there's nothing wrong, or there's nothing new about having boosters, because it has always been there. It's part of the science that also keeps on evolving. Therefore, there's a need for such. We don't know, it might probably, like with a flu vaccine, jab, where it might be every year, you might have to do it for the COVID now and again throughout. We don't know. It might be the case depending on which ones, the variants in terms of where things are. In regard to the vaccine mandate, and also whether the government thinks from the good, what about our staff, what about the government, and also the comment from the Premier. Well, one health system, if I can put it like that, therefore, in as much as that you have got different roles to play. In regard to the labor, to the services, government services, social services, even if you would have wanted to say, for example, before you go to take your SASSA, before you renew your SASSA card, because these are the people actually that you will need to target, those over 50-year-olds, because those are the ones that they have potential to clog health system when they've got COVID, more than the young ones, although I'm not saying the young ones might not be, but we do know based on the evidence of the over 50s. So at what extent now you can say that before Auntie Sarah comes and take the grant, get a jab. Ideally, it could be actually a good thing how you can be able to have an access of the other 450-plus-year-olds, 400, because I mentioned that 1.4 million 50-plus-year-olds in the Western Cape. Out of those 5 million people who have to vaccinate, excluding the children. But unfortunately, it's only about 60%, for example, that are vaccinated. So how can we access those? We could say that. We could say that before you come to Dorp Street as a government employee, you need to be a proof of vaccination. But what we know for sure is about in South Africa, it doesn't work like that. It might be easier to do it institution by institution, which is what is happening with the universities where they're coming with a mandatory. But even before they do that, they have to go to the processes of presenting these at the Senate, the council, and up to all other levels. And then with also with a legal opinion in regard to that space. For us as an employer, we'll never be able to implement anything without the organized labor. So that's why for us, we always consult with them, and that at the national level. Actually, for example, COSATU now, they've done a U-turn where they are fine with that aspect of it. It doesn't stop us also to explore within ours for our staff, but for me, it's about starting with the healthcare workers, because we do know there are other healthcare, I think it's about 60 to 70% of the healthcare workers who are vaccinated. I'm mentioning from the beginning, not only for the booster dose, that are vaccinated. So the others, they are not vaccinated. For me, it will be probable to start with specifically with those, so that we can lead the way and go to the social workers, teachers, and all of those. Ideally, it should be like that. Fortunately, as we always do, we use science. Based on the evidence, from the ethical point of view, from the constitutional point of view, this mandatory vaccination has passed, because we have to protect the others, and also in regard to the Occupational Health and Safety Act, the employer has an obligation to protect you and also protect the others. So it does make sense, especially in a situation where it's in a small ward. I'm talking now about health, and also where we find that you likely that you have to infect the others. In terms of the vaccine hesitancy, I cannot speak on behalf of the Premier, but generally, each and every, that's why when Dr. Kluter was presenting, he spoke about geographic, what is it, in terms of the prioritization, and also the issue of the equitable access. Each and every area has got its different needs. Whilst at the provincial level, they're up there, we can make as many frameworks. Just to make it an example, in Mitchell's Plain, the three areas where we find that there's a lower uptake of the vaccine, especially among the older ones. It's a Mitchell's Plain, it's a Khayelitsha, it's Central Karoo. You might get some of the pockets within other areas. In Mitchell's Plain, there the issue is not about people are not informed, but it's about the role that is being played by the influencers. And the majority of these influencers are the people who have got the knowledge about the vaccine, for example, the GPs and others like the pastors. So these are the people who are highly respected and used to be the source of information for some of the households. So when the GP will prefer, let's say, ivermectin, for example, vis-a-vis the vaccines, and then that household, when you go to that household, when they say that the GP said, I'll listen to my GP, because there's been my GP for my grandmother, for my grandfather, my in-laws is still my GP, so they'll listen to that. So that's why the approach there is about to use the same people who are the influencers to be able for them to become the vehicles to make those people to change their minds, which we have done very well when it comes to working with the pastors there. In Khayelitsha, it's more of about their misinformation in regard to, it's going to cause infertility. It's going to be where I'll ended up not having children, something like that. That's why I'll find that the approach there, it has been more of ask a doctor. Yes, last week I was there in Khayelitsha Mall, where 4 of our doctors from the Khayelitsha Hospital, including some of them, even the GPs from around there, they were there at the mall next to the vaccination site, where it says, ask a doctor. One will go there, I've got these rashes, I've got allergies and whatever. I don't think that the vaccine will suit me. And then the doctor explains, and then they do that. In Central Karoo, Lehamka, for example, there it's about, they are talking about these vaccines that are evil, and then they will even explain what is the, shows that is a devil and whatever, all of those. And it's not only from the older ones, even for the young ones, 18-year-olds, they speak that language. And then you ask, where do you get this information from? It's from their pastor. There we worked through, there's a pastor there from Beaufort West, who assisted us to bring as many of his colleagues so that we could be able to have the sessions with them, taking them through in regard to about the vaccines. And there's been a progress, for example, in regard to, there was a day where we even injected even more than 100, even the Motherville and all of those. Same as with the what we call place Vredendal. in some of the parts where you'll find that there was a whole issue about this is devilish and blah blah blah, all of those. So it's a bit by bit. We are trying to make sure that we customize the messaging as according. I think it was today's last slide. It was all about that. You might have some. Remember, when we talk about it in the Western Cape, we also have got 2 million young people at the universities and also at the colleges and also at the TVET colleges and also community colleges, which is for that group, we have to work with the higher education. That's why I was making an example with the higher health, where in January during the university open days, we will add as part of the packages, which is for them. It's not only for vaccination. You bring the GPV and the HIV/AIDS and the substance abuse and drugs, the whole pack of all of those. In regard to also, I think I've mentioned something about mandatory vaccination and all of those in terms of where we are. And then the issue about the targets and all of those. When we go, Member Dagmo, when you go to, like, I think I'm going to go to Worcester this weekend. When you go to a place, first things first, when they have these pop-up stations, firstly, they determine exactly what is their target. The dashboard, which is it's open for the public. You can zoom there in the dashboard. They will tell you how many 18 to 35-year-olds that are there, vaccinated, registered, and all of those. How many 50-plus-year-olds? So you'll find that there are other places where we'll keep on having the pop-up now and again, where it might start with a pop-up at a community hall, and then changes to the pop-up at a church, and it changes to a vaccine taxi where someone, Auntie Sarah, is hosting Stockfell and all of those, and then it's bringing all the church women coming to come and vaccinate outside her house. So it's based on the targets, because already you'll have checked there, and they'll find that there are about 20,000 older persons, just making an example. Out of those, there are still 4,000 that are not vaccinated. So we customize as accordingly, because the approach is differently. Just to make an example, like at Leo Khamka, we have to bring the music tracks from the GCIS, the music track, where we're targeting older people, but luckily for them, they like to dance. So we did all this jolling and also the vaccination all at the same time. So there is a target that is there. I did mention initially it was a 30,000 for the whole province per day, based on the capacity and also towards what we want to achieve by the end. Remember, we've got 5 million, 4.97 people that is to be vaccinated. Out of those, 1.4 million over 50s. You can divide those. There's 723,000 that are over 60s, and so forth and so forth. So we already have those targets. So that's why we can say we do have a capacity for 40,000 to 60,000 in order to achieve the 85% of the over 50-year-olds by the end of the year, and 65% that are those that are below. And then lastly, Member Wendy Philander, yes, indeed, we are trying as many of the approaches. We've done the farm workers, where some of them it could be we bring the wellness bus, and then especially with the smaller Nyana farms where we just do a stop and go by each and every farm, or we collect them thanks to the farm owners and also the employers who actually have been assisting even to transport some of them. We've done the taxi, working closely with the taxi industry, not only through the red dot, where like a colony where we fetch them from their houses, whether they are in pajamas, because some of them said, oh, I'm still going to. I said, no, you can come. Oh, still I've got a swell coat. I said, no, you can still come. Oh, come with it. Get into the bus. Like even now in Atlantis in that sense, where we've done that. As we've done the home, for example, the homeless. We are the first ones actually who started the homeless. It was about, they don't have documentation. We said at the end, when they become patients, nobody says that, okay, are you earning 1 billion? Are you homeless or whatever? Everyone will get a ventilator, will go to the oxygen and whatever regarding to severity. So we've done all of those. Just before Joel, we have done all of those things. The churches we have done, like now I'm making an example where they just do a pop-up of Exitaxi outside the yard if the families can be able to bring as such. We're still going to do more, but again, we rely also on communities, in communities where they could be able to assist. us as MPs and the MPLs and the community leaders, as the church leaders, we could be able to say, come to this area, we are ready, we will come, because what was taught us is about, it's no use to have all these community halls everywhere, community hall, CTICC, like the CTICC target was about 4,000, which was never reached that 4,000, because some of the people, they would have been there in the vet center, so why would this person will come and take a bus or whatever to go to CTICC when it's not even working that side? So we have to bring the vaccines to the people. And then lastly, 94%.
Sorry, Minister.
It's the last one.
Sorry to interrupt. I have a point of order. Honourable Murray.
Honestly, Chairperson, is the Minister going to take up till 4 o'clock the time? We have a lot of other questions to ask. She's been rambling now for almost 20 minutes.
Well, Honourable Murray, there were a lot of questions that were posed, so let's give the Minister the opportunity. She was concluding now. Minister, please proceed.
Thank you. The last one, in terms of the equitable access, it also responds to that question about the accessibility. As we always say, that availability doesn't necessarily translate to accessibility. So you might have all these vaccinations pop up and everywhere, every weekend, every day, wherever. But are they accessible in regard to, just making an example of Auntie Sarah, our statistics show that over 50-year-olds, 94% of those that have been vaccinated are insured population. These are insured 50-year-olds. Vis-a-vis, I think the 40%, which is from the uninsured population. It means that if we could have a severe fourth wave, the most people who will end up clogging our health system are those who are mostly uninsured, where those who are using the private, probably there might not be as many, because there are many of those who are private patients, clients, who have been able to be vaccinated. Whilst we understand that initially when the country was starting with the vaccination, it was the access was more for those who can be able to do their apps, their phones, they've got fancy phones, they can do the EVDS and all of those. With now the last ones were mostly in some communities who are not being able to. So that's why we are saying that there might be some of the people who are out there where us at the health system might not be able to reach them, but some people might be able to know, so that we can be able to reach as many of those. And again, go to the dashboard, you'll see how many people who are not vaccinated in whatever area and what age group, and we try as much as we can to bring it. Thank you, Chair. Thank you, Dr. Kluti.
Chairperson, can I proceed?
Yes, please do.
Okay, so I'm going to pick up on just one or two key things that cuts across what many people have asked. So I'm grouping them in the following. Vaccine mandatory or mandates for vaccination was asked by at least 4 different members. So let me just clarify. A vaccine mandate by definition is when a workplace or an employer makes it mandatory for people that work or function to be part of that organization should be vaccinated. There are a few people, as Honourable Heron has indicated, like Discovery, UCT has done it, a few other places and some workplaces. The President's call for a task team. Our position in the Western Cape is and I know the Premier is writing to the President to potentially participate in that task team, to be quite happy to participate in the task team. And our position is that as the Western Cape Department of Health, we very much support that there is clarity and there is finality on the development on vaccine mandates, so that everybody knows what the process is, who does it, and how does it actually work out. In terms of how a vaccine mandate works, each individual employer has got the right under the Department of Labour regulations to draw it up on the basis of consultation and following a fair process, and then to say, if you want to actually be at this institution, work here, you should be vaccinated based on the following process followed. For us as Western Cape government, we are public servants. So we don't have the delegated authority to have for employees of the Western Cape in isolation of the Department of Public Service and Administration. Because of our process, we are all public servants, and the Department of Public Service Administration has a process, and we as Western Cape government will have a position in relation to that process as it affects the Western Cape government employees in this regard. As it regards to Parliament, it's an interesting question because Parliament would probably be its own employer. And obviously Parliament as an entity should then follow the same Department of Labour process. And I would imagine that that's a process that each entity can then follow for themselves. I think in terms of the targets, the Minister's answered that to Honourable Dankmo. Every area, every outreach, every place has got targets disaggregated to the lowest level, and they function every day in terms of their targets. In terms of the issue about vaccine hesitancy, I think, again, like the Minister, I can't speak for the Premier. The issue is a lot of what we're dealing with is access. That's why our differentiated model is taking vaccines as close as possible to people. So there's a weekly survey that is being done by, it's a company interviews people and asks them, why have you not been vaccinated? It's an interesting constant figure. About 30% of people said, I just haven't got around to it. About 20 to 30% of people say, I am not sure, I'm still waiting. And if I can turn to somebody that I trust, like a doctor, I might make up my mind to get vaccinated. And 20 to 30% of people says, I'm not going to get vaccinated. So it's not just vaccine hesitancy. There's also the issue of people are just haven't got around to it from a logistics point of view. So it's a combination of all of those things. If I can go very quickly to what Member Christians asked, the prevention measures that we have mentioned is all based on the science and the evidence. The science and the evidence is still outstanding on immune boosters. The science and evidence is not conclusive on ivermectin. I've repeated that a few times at this committee. When the science and evidence is clear and it's unemphatic that there is benefit, it will become part of the evidence-based interventions. The issue about symptoms of Omicron, it's early days. There are suggestions that people have milder symptoms. It's too early to call. We need to monitor it and see what happens. And as more cases become available, we can then make a call on exactly what the symptom profile is. Booster doses, the Minister's explained. Booster doses mainly is because after a period of time, the protection you have for antibodies starts waning after a period of time, and therefore it just boosts it up. And then just in terms of Member Mare's questions, the virus, according to the science that I am exposed to, Member Mare, the virus is real. It's not engineered. It wasn't produced in a laboratory. It's a real virus. It behaves like other viruses. And the vaccine is developed according to the strictest rules of vaccine development that's internationally observed. And that's why we have regulatory bodies. We have regulatory bodies in every country that regulates what is in medicines, what's the evidence, and the regulatory bodies are there to safeguard everybody. So in terms of what's in the vaccine and what it's based is based on the evidence that the regulatory body then investigates, and they do it to protect citizens. In terms of spike protein is an element that's on the virus itself. It's the spike protein in the virus that attaches itself to the human cell that causes the infection and causes the symptoms that Member Brinkhuis was talking about. The spike protein is purely a piece of the virus itself that exists, that attaches itself to the human cell, that infects it, that makes people ill. In terms of comorbidities, that's exactly the reason why people with comorbidities were more at risk, because this virus caused through the spike protein attached to the bodies of people with comorbidities. Because they're more at risk, it caused a more severe disease. And therefore, yeah, the hospitalization in cases in Gauteng, there was an upswing in cases. The hospitalization is starting now. What I showed you is there's the start of an upswing of cases. We expect the hospitalization to increase over the next 10 to 14 days. By the time it increases, we should be ready to respond to the last question, Honourable Brinkhuis. From the Gauteng experience, we need to wait a few weeks or a couple of days so that we can have a clearer understanding whether the symptoms will be anything different from what was experienced in Delta and in Beta. By all accounts, we don't expect it to be much different, but we will wait for it to be seen. But the virus is real. The Omicron will be real. It will be infecting people. People will be ill. Some people will be in hospital. But what we know from the science, in all likelihood, vaccines will help, and therefore we need as many people to be vaccinated. Thank you, Chairperson.
Thank you very much, Dr. Cloete and Minister. Honourable Marais, is that a point of order? Honourable Marais, is that a point of order? Okay, does not.
No, it's not a point of order, it's permission to speak.
Do you want to pose questions?
Yes.
Okay, if you'll just wait your turn, please. We're now going into round 2 of questions. I'm going to start with the DA as usual. Are there any questions from the DA?
Chair, may I?
Sorry, who's that?
Van der Westhuizen.
Yes, Honourable Van der Westhuizen. Off you go.
Yes, thank you, Chair. I would like to know, we've seen a very interesting trend with infection rates in the sense that we talk of waves. What would be the reason why this virus is behaving or the infection rates is behaving in waves? Has it got to do with the fact that every wave has seen some lockdown regulations and a clamping down on movement, etc.? Or could there be other reasons for that? And then secondly, we do know that people have to wait 15 minutes to see if there's not an allergic reaction to the injections. And I think that time may also be used as an excuse by people that are looking for excuses. Have you seen any allergic reactions to people? I think you call it anaphylactic reactions after the injections. Thank you.
Thank you. I also have some questions, if I may. Dr. Cloete, I've seen some reports that the pediatric COVID wards in Gauteng and specifically Baragwanath are full. In other variants, children have largely been unaffected. So I'd like to understand if it's possible that that a variant may change its target profile, and is this something that we need to keep a keen eye on? You know, as a mother of a small child, there's a sort of worrying indicators. If you could just tell us a little bit more about this, and I know it is early days, but some more information would be valuable. Then my second question is on the number of days for symptom onset. Now, from what I can tell, in the beta variant, it took about 6 days for symptom onset on average, and with Delta, it was shorter to 4 days. Is there some anecdotal evidence that Omicron's symptom onset is even quicker, to 2 days? I just know anecdotally a few people that seem to have, had symptoms after 2 days. Do we know anything about that yet, or again, is it too early? And then the final question is, the health department is now facing, for the 4th time, a wave that will put it under incredible pressure. And I know it's very difficult, both physically and mentally, for healthcare workers to go through this, or to face the prospect of going through this yet again. And I'm sure the same applies to yourselves as the management of this team. How are you preparing, and how are you preparing your team members and motivating them to face this and get through this in ways that they have done previously and done so well? And the question is raised out of concern for you all. Thank you very much. I think that then are the questions for the DA, unless there are any others. None, all right. Oh, okay. So that then concludes the questions for the DA. Then let's move on to the ANC. Honourable Windvogel.
Thank you, Chairperson. Chair, mine is on the issue of the infections in the Garden Road. I want to know from the department, what do they think is the major drive behind high infections, and what is government's response? and whether there are any vaccinated persons who have been reinfected and hospitalized with the new variant. Thank you so much, Chair.
Thank you. Any further questions from the ANC? If there are none, then let's move on to the Good Party.
Thank you, Chair. Chair, I just want to go back to the question of vaccines hesitancy and the slow rate of vaccination. I mean, we just yesterday received the latest labour force quarterly report, which shows a massive jobs bloodbath, and that can partially be attributed to the lockdowns that we've been through over the last almost 2 years as a consequence of this pandemic. Now that we've heard from both the Minister and the HOD that vaccinations are key to us overcoming this pandemic and maybe getting back to some sense of normalcy or getting an immunity within our communities. So I'm a bit concerned about the lack of urgency that I'm picking up, and maybe I'm wrong, when it comes to how we can insist or assist people to become vaccinated. And I'm talking about a vaccine mandate. And I think it's important that we cannot, plod along waiting for or participating in task teams and stuff when we actually should be implementing mandates where we can. So the Minister spoke about that she would support it for healthcare workers, but she didn't say whether that's been implemented for healthcare workers in the Western Cape, that all healthcare workers must be vaccinated. So I'd like to understand what steps have been taken there. We have large employers in the Western Cape. Old Mutual is a large employer in the Western Cape implementing a vaccine mandate. And as a government, do we not have an obligation to also lead when it comes to this and not just observe while other employers implement mandates? Dr. Klute describes a vaccine mandate as an employer requiring an employee to be vaccinated in order to be in the workplace. But the vaccine mandate can take many forms. Some countries have made it absolutely compulsory for every adult to be vaccinated. Other countries have made venues require proof of vaccination in order for people to enter them. So, in this space, and neither the MEC or the Minister or the HOD responded to my question about the provincial government implementing a mandate when it comes to places like restaurants and bars, where we control liquor licenses and policy around on-consumption liquor. So I'm going back to vaccine mandates and whether this government is going to move forward with a vaccine mandate, or whether we just going to, as the HOD said, participate in a task team gladly. I think we need to do more than that. The MEC mentioned students and first-year students and getting them vaccinated, but we know that in the Western Cape, the UWC and UCT have already adopted vaccine mandate policies following UFS and WITS. So, I mean, there are universities implementing vaccination mandates, there are employers doing so, and where our government is able to implement a vaccine mandate, I'm really asking why we're not doing so. Thank you.
Thank you. ACDP, any questions?
Thank you, Chairperson. Yes, I have a few questions. Just the one. I know it's not mentioned, but if Dr. Klute can give us just the recovery rate of children between the ages of 12 to 17, I believe it's almost 100% recovery rate. And why does he think that, the SAPRA has approved that children from 12 to 17 must be vaccinated? Maybe that is the one question. And I cannot understand why some political parties is driving this mandatory vaccination so hard, because it's the president of the country that did a backflip. He said nobody will be forced to be vaccinated. Nobody will forbidden to travel and all of those type of things. So that he said he backflipped on that. We also, if you read in the media, I mean, there is public sector unions that refuse to support mandatory vaccination. The PSA, POPCRU. I see the Nursing Institute, the NOSA must now, they deciding what action to take and how to respond to this. But I don't think it's a lack of the government or the department of getting people vaccinated. I think there's also people that's resisting a vaccination, and I don't think it's a lack of department. There is people out there that do not want to be vaccinated, and like I said, AgriForum, the ACDP, and all these, we as a political party are taking government to court for the 12 to 17, and as I said before, we are going to take government to court for the mandatory vaccination. So we still believe in freedom of choice. We believe that people must not be forced to vaccinate it. And I still believe we still believe there's other ways of getting over this virus. Ivermectin has worked for over a 40-year period. 10 million people, 1 billion people were used ivermectin in the past. There's statistics. The hesitancy with this is that this is still not vaccines are still not proven. It's an experimental vaccine, and not like the minister said. All the other vaccines you must go for yellow, and those are proven vaccines. This is a experimental vaccine, and people are not comfortable. Many people, and I still believe from outside, from the ACDP side, that although parties is pushing for that, people must have a freedom of choice. Thank you, Chairperson.
Right, then let's move on to Freedom Front Plus.
Yes, Chair Lady, thank you so much. And just Dr. Klute, thank you very much for knowing what the ingredients are. The minister didn't know, but I can tell the minister I know what the ingredients are about all these pain tablets and what I use. It's on the box if she didn't know. Just read the pamphlet inside the box, Minister. But the point I want to come to is that we haven't spoken about the millions worldwide and in South Africa dying of hunger. We're more worried they shouldn't die of COVID, please, but die of hunger, that's okay with us. 155 million people around the world have now experienced chronic levels of hunger because of COVID, the result of COVID, and businesses are closed and people are unemployed and there's no income, but we're worried about making it mandatory. There's other lifestyles that people can also should be prohibited and made mandatory if it's about passing on of HIV and others. We've done nothing about it. And HIV is a bigger killer than COVID. But we haven't heard in this house, they said we must take steps to stop those type of activities, interpersonal activities that spread HIV. So I think you are not going to touch people's privacy, bodily integrity, and their right of choice. I think we're on very, very dangerous ground if we want to force people to take a vaccine, even against their religious beliefs. And here I back the ACDP 200%. Nobody will push a needle in my arm. Death is inescapable. Whether you die from a car accident or whether you die from falling off a mountain or COVID, it's the same death, the same end result. We must push up people's nutrition so that they can have their own immunity systems in check. We don't give people food, but we expect them to be healthy and have an immune system that can fight off coronavirus and any other disease. We rather pump them full of toxins than to give them food. That's the last thing I would like to say on this subject. The rest I will leave for SOPA.
Right, that concludes the questions for this round, which I think will most likely be the final round for today. But let's see how we go with responses. Obviously, some heated debate here and very differing views on vaccines. I'm going to hand over to the Minister and the HOD now to respond to some of those questions, please.
Thank you, Chair. I'll only respond to one question and then the HOD can respond to the others. But the most one, I think, is from the good, again, on vaccine mandate. I think what Dr. Klute was saying was that as an employer, firstly to us health staff, us. We cannot be able to impose. We can make a recommendation. Why? Because it changes everything, because they become an employee and the employer, as a member Haron know, that it activates the labor laws. Hence, Dr. Kluti was saying that the Department of the Public Service Admin, they are the ones that who could be able to come up with a policy framework, because if you could just impose that, there will be a labor issue, there will be labor court issues in regard to that space. Hence, I was saying that for us, we want to journey with our organized labor so that it becomes something that we own it ourselves. So you cannot be able to impose in this regard. Now, about the others, I was making a recommendation, suggestions. I was saying that for me, we as HAP are supposed to lead by example, where instead of chasing after others, that it's mandatory, must do this, as I'm talking now from the public servants side, from government. All health, not only in the Western Cape, should be the ones who lead by example. And then if the labor laws will permit, actually, I'll be the one who will be standing there and say that all healthcare workers, starting from those who are at the cold front, because you don't want to say only those, because people can keep on changing, then they can be admin, they could be wherever, should lead by example in this regard. Now, what about the others? Any sector can be able, as an employer, can be able to do what the universities have done. This is a higher education sector. They are the employers. It didn't come from Minister Blade, but it came from, because they are the institutions. So they could be able, which is what they did, and they follow those processes. But for them, at least those processes are not as same as us, processes as public servants, because they are not public servants. Same as with the discovery. And it doesn't, with the sport, actually, they already said that. When you come to our events and talk about the leisure and the sectors, the leisure and entertainment sectors, they could be able to say that before you come to watch a Bafana game, it's mandatory that you are vaccinated. Before you come to watch whatever, the music show, you should be vaccinated. But the issue that I was trying to highlight, that it's going to be difficult to impose such when it's about the right to access some of these basic services. For example, it might be difficult to say before you enter Kylie Charm Mall, you must be vaccinated, because you might be denying that person the right to access food. So it might be difficult, but it doesn't stop in the Kylie Charm Mall for a certain restaurant to say that before you come for lunch, sitting here for the lunch, you need to be vaccinated. So that's why we're saying that the Department of the Public Admin, working together with even at the bargaining, because some of these things are happening at the bargaining chambers, they could be able to do such. What I know in the task team that the president has suggested, I bet you is going to be more on the access to the events, bigger events, and also other institutions, but it might be difficult to impose this for the whole of the public as a whole. I think Dr. Kluti can continue with the others.
Thank you very much, Minister and Chairperson. Also, I think Minister's clarified to Member Erin. I apologize if we weren't clear. Our urgency is, as a health department in the Western Cape, we've seen the benefit of vaccine mandates. We've seen what it can do in terms of coverage. So we are urgent about getting as many people protected as possible. Minister has explained that we, as the Western Cape Government of Health, have met with all our HAIs. We meet with them regularly. They've actually brought the issue to us because about how it's going to be implemented. So from a workplace perspective, we are public servants. We have a very clear position. We articulate that to DPSA, and we want urgency from DPSA in being able to give effect to something for which there is evidence that it will help us with our coverage. As you can hear from the members on the floor, there's a lot of contesting views, and there will be it will have to be decided in a court of law whether it is constitutional or unconstitutional to mandate somebody to be vaccinated or not. I guess there's case law everywhere in the world. It will end up in courts here, and ultimately a court will decide whether it's constitutional or not constitutional. I think in terms of the other questions, so the infection rates and the waves. Thank you, Honourable van der Westhuizen. This is another reason why this is a novel coronavirus, but what it is a coronavirus. And just to also illustrate to everybody, this is not the first coronavirus. There's multiple coronaviruses that's been around for a very long time. It is just that this coronavirus had a specific set of characteristics that made it novel. So just to use an example, most of the flus that everybody's been getting for the last 50 to 80 years has been caused by coronaviruses. This one is just novel because it had a change in characteristics that made it that there was no immunity built over a period of time. That is what happens in a pandemic situation. But coronaviruses has been causing flus all along. It's behaving the same way that all other coronaviruses have been behaving. Why? Because that's why we call it, we have flu season, we have gastro season. So as temperatures changes and conditions changes and immunity amongst people changes, it has a seasonal variation. So it's not anything unique to this virus. All viruses behaves in a seasonal pattern. In terms of allergic reactions to vaccination, there is a very clear app to report any adverse events in relation to vaccination. I can tell you of the 4 million vaccinations done in this province, there has not been many, if at all, any anaphylactic response to 4 million vaccinations administered in this province. That data is available. We make it public quite often, and that was done by SAPRA because SAPRA has to actually report on all of those. And that detail is available on the SAPRA website of exactly how many vaccination, how many adverse anaphylactic reactions. From our perspective, virtually no anaphylactic reactions has happened here. In terms of Member Wenger's points, Member Wenger, I saw the pediatric ward report from Gauteng. I would caution about people jumping to conclusions what that means. I was at the Red Cross Hospital myself yesterday. There is a respiratory illness wave for children in Red Cross and in Tygerberg, and it's got nothing to do with Omicron or COVID. It's an ordinary flu that's currently being diagnosed with more children with respiratory symptoms being admitted into Red Cross Hospital. So we'll be very careful about making an association of what we're experiencing as a respiratory, a kind of respiratory surge that is linked to something called H1N1, which is the normal annual circulating flu. The symptom onset, it's again too early to make any calls on that. And it's better to wait before we make assumptions about that. And then the fourth wave, physical and mental preparation. Our teams have been through multiple waves and coming out, and I just made a very key reflection to you. We are extremely proud of the fact that after the second wave, we implemented something called intentional grieving and healing. We've been doing that in an intentional way by taking everybody into a process of sharing how it feels about grieving and healing and what is required. We've gone through the third wave, and we've come off the third wave. We've presented people with leave, the 2-day leave that everybody took. And we also intentionally asked people to rest because a fourth wave will come. I've been so heartened by our staff because everybody that I come across says, we've had our interwave break. We know the fourth wave is coming. We are tired. We're mentally exhausted. We're physically exhausted. But this is the job we do. I spend the whole day today talking to people that are EMS personnel, forensic pathology personnel, after I've spoken to the people at the Red Cross. We have the most amazing staff members in this province, and I couldn't be prouder of how people actually still have a calling to do something that is beyond, it's a purpose that they serve. And they take pride in the way they do it, and we really commend and take our hats off to everyone. In terms of the infections for Member Windvogel, Member Windvogel, there is higher infections now. Again, it's early days to say how many of them are reinfected, how many people have been hospitalized, how many people have been vaccinated versus not vaccinated. All of that data will become evident over the weeks ahead of us. It's too early to make that call, because we don't have sufficient data to be answering that questions. In terms of the recovery rate that Member Christian is talking about for 12 to 17-year-olds, it's an extremely high recovery rate, as you indicated. The reasons why SAPRA made the ruling that 12 to 17-year-olds could be vaccinated, it's on the basis of the proven evidence that there is a protective factor for people between 12 and 17 for A, being infected, and B, for a group of people in 12 to 17 that have comorbidities, that it is beneficial and protective to them as it would be for people over the age of 18. That's the reasons why SAPRA has done it. You are currently challenging that in a court of law. The court must rule whether that has been constitutional. Then I think the issues, the others are more statements from your side, Member Christian, so I'm not going to comment on the statements you make about freedom of choice, about the resisting vaccines. It is real. There is a group of people that are set on not being vaccinated. That's real. They have their reasons. And obviously we work on the premise to present everybody with all the information we can, offer them access to a doctor, but ultimately the person will make a decision whether they're vaccinated or not. And then Minister Marais, Member Marais, it is undisputable. There's a NITSCRAM study that's been done by a group of researchers. It's undisputable of what the impact of COVID has been on society in the world, what the impact has been in our setting here. One of the biggest impact is children going hungry, households going hungry, people not having food to feed their children. It's real. It is a humanitarian crisis. And as society, we need to deal with that issue because we will start seeing more children that's malnourished because of the lack of food and at household level. So we should not be turning a blind eye to the humanitarian crisis. We should be doing everything we can to assist people in terms of feed and the humanitarian issues. I just want to make the last point, and which is what my member Aaron then also said. The distinction between a mandate for a workplace and a distinction between mandate for a workplace and then mandates in terms of societal access to societal activities. Those are obviously very clear and it's important. And as Minister Mbombo said out of the task team, it will be these two things. It's about workplaces, public versus private workplaces, and then mandates for people being denied access, or there's a requirement if you want to participate in certain activities that you need to be vaccinated. Now, obviously, all of that will play itself out over the coming weeks, and it is important that there's clarity on that either way, and it needs to be tested in court. It needs to be tested in court because we need to move forward. Thank you very much, Chairperson.
Thank you very much, Dr. Cloete, and to the Minister. I think that then concludes the rounds of questions for today. We do have some committee admin that we need to get through hereafter. But before you go, I mean, I just, in my parting words, I'd just like to say the evidence in support of vaccines is overwhelming, in the billions of doses that have been administered around the world. And given the identification of the Omicron variant and the trends towards a fourth wave of infections, which have been mirrored by the projections we've seen today, I think we as parliamentarians have a duty to raise public awareness on the importance of staying safe at this time. As public representatives, we also have to help residents separate fact from fiction and to make sure that we're all following reliable and scientific evidence to share the best public health advice. And, you know, we need to reach a stage where we can prevent further variants from developing, to help our health systems from not being put under strain, and where our daily lives and economy can begin to recover. And the only way we can do that is by encouraging as many vaccinations across the length and breadth of not only the Western Cape, but the country in its whole. And so I would like to then say, get vaccinated. I got mine. And in closing, I'd like to thank Dr. Mbombo and Dr. Cloete and your team, as well as every single healthcare worker in the province. The work that you're doing is really remarkable, and we too are very proud of you and grateful for your care. We keep you in our prayers and pray for strength and courage as you face this next challenge. Thank you very much.
Thank you, Chairperson.
Thank you, Chair, and thank you, honourable members. Thank you also, Dr. Kluti and staff. Thank you.
Thank you. Go well.
Bye-bye.
Members, are there any resolutions or actions emanating from today's meeting, please? Or any requests for information? If there are none, as always, you do have the opportunity to submit any additional questions or requests for information by Monday, 12 o'clock. That's Monday, 6th of December. And then that will be included in the next meeting where we can have a look at those recommendations and requests. All right, then let's move on to the committee admin. We have 2 sets of minutes and 2 sets of draft reports. I'm going to hand over to the procedural officers and thank them very much for all the work they have done in preparation for today's meeting. All right, here we are. We're starting with the minutes of the 25th of August. All of the documents have been forwarded. Would members please just make note of the attendance register there? All right, we can go down page 1, page 2. And page 3. Are there any edits or amendments? Honourable Philander.
Chairperson, I move that we adopt the minutes of the 25th of August.
Thank you very much. May I have a seconder?
Unfortunately, I wasn't present for that meeting, so I'm unable to second.
May I have a seconder then?
I second, Chairperson.
Thank you very much, Honourable Binvogel. Then let's move on to the draft minutes of the 3rd of September. Honourable van der Westhuizen.
Sorry, Chair, you probably still, I'm a bit quick, you probably still want to present the different pages.
Yes, I'm sure you've read them already, so there we are. I'll just give the others an opportunity. Just have a look at the attendance register there. This is the 3rd of September. Page 1, page 2, page 3. All right, Honourable van der Westhuizen.
Propose that we adopt.
Thank you very much. Honourable Bartman.
I second.
Thank you very much. The minutes then are duly adopted. We then move to the draft committee report of August. Okay. The first 2 pages are the same for all the monthly reports, so I think we can just go through there. And then page 3, the theme was for that month was Health Department responses and preparations. Page 3, any edits or amendments? Page 4. Any edits or amendments there? Page 5.
Chair, I would like to propose an amendment or just a correction there on page 5.
Yes.
Perhaps if we could just be scrolled up slightly. I think there's a word there when it comes to the mass vaccination site, and then also I think the word should be, sorry, I think, can you scroll up a little bit more, previous page? Thank you, that's it. In the middle of the page, that the Metro Mass Fatality Center has capacity for 240 bodies, currently 11. I think it should be deceased. The word decedents I couldn't find in any of my dictionaries.
Right. I'm also, let's have a look here. All right, let's change that to deceased. There we go, perfect. All right, thank you very much. Anything further? Honourable van der Westhuizen, was it only that one correction?
Yes, and I propose that with that small correction, we adopt the report.
Thank you. Could I have a seconder for the report with an amendment? Honourable Philander.
Duly seconded, Chairperson.
Thank you very much, Honourable Philander. Then the final document is the draft committee report for September. All right, let's go straight to page 3 because page 1 and 2 are always the same. The theme here was intergovernmental relations and community cooperation. This is when we had the Twitter influencers, the COVID Actuaries Group and the Department of the Premier. Page 3, any edits or amendments? Page 4. Any edits or amendments there? Honourable van der Westhuizen.
Chair, no amendments to the document itself. I presume it's the hard copy that will be filed, but perhaps we could just note that the spelling of September in the file name should be corrected.
Oh, got you. Thank you. Honourable Bartman.
Seconded.
Okay, thank you. Then page 5. Page 6. Page 7. 7, nearly there. And then page 8. All right, can we go ahead and adopt these this report?
Agreed.
Honourable Bartman.
I propose we adopt.
Thank you. Honourable Botha.
Chair, I second that proposal.
Thank you very much. The report is then duly adopted. Honourable Philander. Okay, it was obviously to adopt. All right. That then concludes the committee admin for today. Thank you very much, members, for your participation in today's meeting. As mentioned, this is the last scheduled meeting for the year. And let's hope that we don't have to return during a recess like we did last year. I hope that you all keep safe and healthy, and I look forward to seeing you in the ad hoc committee again in the new year. I'd like to thank our procedural officers, Ms. Hassan Musa, Ms. Jones and Mr. Daza for their incredible work over the course of the year. They really have worked very hard and have been excellent procedural officers, and we extend on behalf of the committee our sincere thanks to the three of you. And we hope you can have a good break once Parliament closes its doors for the year. Thank you very much. The meeting is adjourned.